Hey everyone, and welcome to our final week of content for Respiratory 4204. So we're going to cover ECMO, some advanced modes of ventilation, and a little bit of gas therapy. When I say advanced modes of ventilation, I more or less mean alternative modes of ventilation. You've all been exposed to these things before, but may have not used them very often. So advanced, alternative, whichever way you want to look at it. So tonight, like I said, we're going to go over these topics. Next week, we're going to have our final exam review. So I'll put up a recording that goes over the review that I provided about a week ago, and some reminders here at the bottom that you guys can follow up on when you refer back to this PowerPoint. So let's just jump right into it. So we're going to begin with our first relatively advanced, more or less different mode of mechanical ventilation. This is proportional assist ventilation. Now, this is an interesting mode, and it's something I haven't used very often. So on the Puritan Bennett, which I'm used to using, so the PB840, there is a PAV mode, and it's kind of interesting, and I've used it in situations where we really couldn't just figure out how to make this patient comfortable. And in those situations, it didn't work well because us as clinicians, or we as clinicians, did not know how to use it. But with some practice and time and understanding, I learned how to use this mode of ventilation. Does that mean it's a good mode of ventilation? Who knows? Sometimes these things are created to fix a non-existent problem. But anyway, so PAV is basically a spontaneous breathing mode, and it doesn't really target anything that we're used to. So we're not targeting a flow, we're not targeting a pressure, and we're not targeting a volume. Although it is pressure support, we are adding parameters into the system in this feedback loop that are going to respond to changes in the patient's ventilatory demand. So the ventilator offers assistance based on the demand of the patient. So if the patient's taking a big breath in, it will provide a little bit more support in proportion to what you set. We'll get into that in a second. If the machine senses more resistance, it will provide more pressure to overcome that resistance, or an increase or decrease in compliance, it would subsequently adjust its parameters within your alarm settings, so almost like PRVC. But at the end of the day, the ventilator offers assistance in proportion to the patient's efforts, proportional assist ventilation. This is what the waveform kind of looks like, and it looks almost just like any other pressure support waveform. You see the patient taking different flow rates in as far as their spontaneous breaths. You see our pressure is held constant here, so we know this is a pressure mode of ventilation. But how it works really is based off the equation of motion, right? So the equation of motion states that the volume and elastance are directly proportional to flow and resistance. Well, what the ventilator is doing is taking out, so this is ventilator assist and this is flow assist, is taking out these issues that are associated with each of these proportions. So our ventilator we're going to subtract that assistance from our elastance in our lung, because that is a pressure we have to overcome when we take our tidal volumes, right? And of course, if we subtract flow assistance from which the ventilator would provide in this mode of ventilation, we're augmenting or overcoming resistance that is imposed upon our patients via endotracheal tube, increased dead space in tubing, and so on and so forth. But you see here with this flow waveform, this patient is taking a big effort, and you notice how this pressure, and when I mean constant, I mean more or less it's a square waveform. Obviously this isn't constant, but this pressure is increasing to support this patient's breath, okay? Now, the way this is set, at least from what I'm used to, is you set a percentage of what the ventilator wants to do. And initially, you usually set this, now remember this is a pressure supported mode. Initially, you set this at 80% of the patient's perceived effort, right? You'll set PEEP and other things like that, but the ventilator will use an algorithm and adjust coefficients here within this equation to give the appropriate support. We don't have to get into that this discussion, but just understand that we are setting a proportion that assists the patient. So we can give 100% assist and to be almost like a pressure support system. So essentially it's used for a weaning mechanism, something to make people with air hunger and constant dyspnea a little bit more comfortable on the ventilator, so people with COPD. But these patients have to have an intact respiratory drive, and they can't, basically any criteria for them to be on pressure support, they probably could use this mode. Exceptions would be patients with Guillain-Barré or some sort of neuromuscular disorder where the ventilator won't be able to compensate well enough because they can't generate that effort for the ventilator to identify the support the patients need. And ventilator-dependent patients clearly have marked dystrophy and weakness. So they're actually going to work harder on a mode of ventilation like this. So basically our spontaneous breathing patients, some of our COPDers, I really would be reluctant to do that, but there's some evidence that shows that PAV actually increases the patient's comfort on the ventilator in patients with COPD and exacerbations as such. But just like PRVC in these kind of modes, the bigger breaths these patients take, or their tachypnic or whatever it may be, the algorithm that's associated with these programs gets kind of all wacky, and it doesn't really support the patient well, and actually can cause more dysynchrony and more discomfort. And that's my experience actually that I've had with the handful of times I've used PAV, but like I said, it can come down to user error as well. But the advantage is that the patient drives the ventilator. Like I said, we're not necessarily targeting a pressure, we're not necessarily targeting a flow, we're not necessarily targeting volume. The patient determines these things. So when the patient determines these things and we set an appropriate percentage of workload, the patient will be theoretically more comfortable and have less asynchrony. So basically they're breathing like they normally would, despite the fact that they're getting positive pressure into the lungs. But the ventilator is working as a different neurological input and allowing and adjusting appropriately, so there's not that lapse between machine and human. Basically, there's been some research that supports that people sleep better when they're on this mode of ventilation. We have less sedation, which I think is obvious. If you make someone more comfortable, make someone more synchronous with the ventilator, you don't have deficits in either one of those areas. And it also keeps those respiratory muscles working despite the augmented pressure support. Here's a kind of a representation of what we're seeing with as far as our respiratory muscle activity and the pressure that PAV supplies. So in pressure support ventilation, regardless of respiratory muscle activity, we're going to get the same pressure. It's constant. We set that pressure. PAV will adjust to patient's inspiratory effort. And again, this is based on our percentage of workload that we're providing the patient. So if we set this at 80%, it will adjust accordingly. But some of the disadvantages are that the patient has to have an adequate spontaneous respiratory drive, which I think is fairly obvious if you're having someone on this mode of ventilation. You're going to have a variable tidal volume and PIP. Like I said, we're not setting necessarily a pressure or a volume or a flow. Determining the lung mechanics of the patient is difficult. This is hard to really interpret bedside, and this is the problem with these servo-regulated mechanisms. We can't really fine-tune these things, and these algorithms are relatively precise. So in essence, at some point, we're going to be over or under our goals. If we have an air leak, let's say in our endotracheal tube, where this person has a spontaneous pneumothorax and they have a chest tube and they have an air leak, we can have excessive autocycling or assist, which can happen in any mode of ventilation as well. Depends on what your flow trigger is set at. And then, of course, just like any other ventilator, your trigger effort may increase with auto PEEP. So someone with COPD or asthma or who's hyperventilating and generating auto PEEP, they're going to have difficulty triggering the ventilator if the trigger is not set appropriately. But some things to remember with PAV. Expect higher respiratory rates with these patients. Why do we expect that? Well, we're making them work, right? We have to assess them for comfort. I'm not comfortable with patients breathing that much when they're on a ventilator when I feel like I can do something about it. To me, it's almost like putting someone on an SVT and watching them just be tachypnic the entire time and not having a good time. Tidal volumes might be a little bit lower, which is a high respiratory rate to compensate. And this is also because the patient might be switching to this mode of ventilation and actually using their respiratory muscles more, getting more conditioned, and hopefully this will change. And every 4 to 6 breaths, an automatic plateau pressure is performed as a protective mechanism for their lungs, okay? Because we are delivering pressure to the lungs, we want to keep it at a certain plateau pressure to avoid any sort of barotrauma. All right. All in all, I wanted to introduce this mode of ventilation because it's kind of gaining steam. You guys might have a little bit more experience with this mode of ventilation. I personally am not a fan of it. I think clearly in this slide, to me, this doesn't make any sense. It sounds like a failed SBT in my opinion. But there is some research out there that says that it works a little better in certain patient populations. But just so you know, this is a mode of ventilation that might be available to you. You might have a physician request this. So you have this background knowledge, do a little bit of digging around on your own, and understand what goals we're trying to achieve with PAV. Now here's APRV. So APRV, again, these aren't advanced modes of ventilation, but they're alternative modes of ventilation. But APRV has been around since about 1987, and APRV doesn't really mean anything. APRV is almost a trade name as well, but it just describes what the mode of ventilation does. So the Draeger has APRV, the Hamilton G5 has APRV, I think the Puritan PB840 has bi-level, and then the Servo-I has bi-vent. I usually get those two mixed up sometimes, but it's all the same difference. But basically, it was initially described as CPAP with a release, right? And that's still what it is. But the physiology behind this is that we keep people oscillating around the middle ports of our pressure volume loop. So those inflection points, we want to keep them in the middle of that sweet spot, right? So the physiology behind this is that we're keeping the lung open for a longer period of time. The patient is able to breathe spontaneously within this realm of CPAP, which is usually set around either the plateau pressure or the peak pressure. It depends on what mode of ventilation you're sequencing from. And you kind of oscillate around those pressures with your spontaneous breathing, and then you have a pressure release to augment some sort of tidal volume, right? If you kind of think of a balloon pump, the way a balloon pump works, during systole you have an inflated balloon pump. During diastole you have an inflated balloon pump, and during systole you have a deflated balloon pump. It's kind of the same thing, you're augmenting that tidal volume. But with APRV, you need to have a spontaneously breathing patient. You don't necessarily need to, but the ideal patient is spontaneously breathing. And this is something that we often come into problems with APRV. You'll have a sedated and paralyzed patient in APRV. I don't really see the benefit in that. We can have them on conventional mechanical ventilation that's proven, and not worry about an increased elastance of the lung due to a paralytic, for example. But let's go over some general settings now. We discussed the physiology about it. We want to keep the lungs open, keep recruitment open, offer a short T-low time, auto-trap a little bit, and then go back up to P-high, right? But some of our initial settings are relatively arbitrary, but there is some sense behind them. So basically what we're going to want to do is we're going to want to have our P-high transferred over from our previous mode of ventilation. So this could be either from our peak pressures if we're in pressure-controlled ventilation, or it can be from our plateau pressures from volume-controlled ventilation. Now, what do you think the issues are with that? If you're in a volume-controlled mode of ventilation and you have a spontaneously breathing patient like you would like on APRV, how do you get a plateau pressure? In my opinion, you cannot get an accurate plateau pressure on a spontaneously breathing patient. If you have a spontaneously breathing patient on volume control, I don't think that's very nice as well, because you are limiting their flow. Remember, that is a constant. But we're going to transfer that over for our P-high. So we'll have a P-high setting. And this will be like our CPAP setting, right? It's all the way up high. So generally, let's say you have a really sick patient and your peak pressures are 30 centimeters of water pressure, because that's what you set them at on pressure control ventilation. Well, guess where you're going to set your peak pressures on, or your P-high on APRV? 30 centimeters of water pressure. Now, you can go plus or minus 2 depending on the patient. If the patient's obese, if there's other extra pulmonary things going on, or within your clinical assessment, that P-high might actually be higher. And this is where an esophageal balloon will come in, but we're not going to get into that. Our P-low we're going to set at 0. Now, our P-low is theoretically our PEEP, right? Oftentimes, you'll have some discussions with certain clinicians about setting a P-low. Now, I want to clear this up right now. You set the P-low at 0 because we want to air trap in these patients. We want to provide us a sufficient T-low that we're not de-recruiting our lungs, but we're providing enough time for gas exchange to get CO2 out, okay? Why do we even do this? Why would we even just offer this mode? Why don't we put them on conventional modes of ventilation? Well, when we inverse the ratio, these are issues that we come with, okay? When we inverse our ratio, we have to take this into account. If we have too long of a T-low, we're going to de-recruit and completely negate the positive effects of APRV, or the theoretical positive effects of APRV. So we're going to set our P-low at 0, right? So we're going to set our PEEP at 0. Now we're going to set our times. We have two different times. We have a time high and a time low. Time high and time low are kind of iffy to set, but generally we're talking about initial general settings, right? You just got a patient, you're going to throw them on the ventilator. We're going to set our time high at 5 seconds, okay? And we're going to set our time low at 0.5 seconds. Again, there is some nature of arbitrary conclusions that are drawn from these settings, but these are like your general settings if you set a patient up on conventional ventilation, okay? So obviously you adjust from here, but these are safe general settings and you assess from this point. Now, what kind of respiratory rate do you think that would give you? Well, you have to take into account the time high and the time low, and you're going to treat that like your total cycle time. So if you add your time high and your time low, so you have 5.5 seconds now for your total cycle time, 60 divided by that number will give you about 11 breaths per minute, right? It kind of works like that, it kind of doesn't. So if we increase or decrease our time high, what do you think happens? Well, we increase the amount of releases. So that can be like increasing your respiratory rate. We'll get into that a little bit later. But those are your general settings. So you'll set your P high from your previous conventional ventilator settings or whatever you perceive of that patient. If you are putting this patient on APRV as an initial mode of ventilation, you're going to set your P low at 0. You're going to set your T high at about 5 seconds, 5 to 6 seconds or so, and your T low at about 0.5 seconds. So let's troubleshoot these settings. So let's say you had a patient who is hypercarbic on APRV. So if a patient's hypercarbic on APRV, what are we going to do? Because these aren't normal parameters that we're used to using, right? So if a patient is hypercarbic, we're going to adjust a few things. Now we have 3 different things we can do. We can either increase our P high, right? So we're going to recruit more lung and we're going to have a bigger drop, right? So we're going to have a greater delta P. Okay, we can do that. We can also decrease our T high so we have more releases. Finally, we can also increase our T low, which would give us more time to expel that gas, right? There's issues with each one of these interventions. So this is why this mode is so difficult to manage, because you really have to critically think. So if we increase a patient's P high, what are we going to run into? Well, we're going to run into volume issues. We're going to start backing ourselves against the wall as far as our plateaus or whatever we're concerned about there. And then also, we might lose some protective mechanisms, but the P high would be very effective if we think we're still kind of de-recruited, right? So that driving pressure might recruit those de-recruited alveoli, which will improve gas exchange, which would in turn reduce our CO2. Now, if we reduce our T high, what we're going to do is effectively increase our respiratory rate, right? But if we reduce our T high, what do you think can happen? So think about when you have someone on a mechanical ventilator, conventional mode, and you're kind of backed against the wall, but you can maybe increase their inspiratory time a little bit to maybe give them a little bit more mean airway pressure. Well, if you decrease your T high, you're kind of taking that away from these patients. So you're decreasing their mean airway pressure, which might cause them to become hypoxemic or de-recruit, right? It's a double-edged sword. Now, finally, with your T low, obviously, if you increase that to mitigate hypercapnia, you can cause de-recruitment and lung injury, so induce villi, okay? So you have to take all these things into consideration with a grain of salt. So let's talk about hypoxemia. So how will we address hypoxemia on a patient on APRV? So a patient on APRV with hypoxemia could be suffering from a few things. They could be suffering from an inadequate T low. So a too long of a T low, which I'll talk about in a second, how we can determine that. P high might not be high enough. So we can increase our P high. We can decrease our T low with all things considered. And we can also increase our P high, if I said that already. T high, P high, we can increase. We can decrease our P low, okay? And of course, what do we get out of that? Well, we can get overdistension, we can get hypercapnia, but you can see how these things kind of work together, and it's almost a flip of what we're normally doing. So just to recap, our T high is a driver for our release and our respirations in a sense. If we have a too long of a T high, it doesn't really help with the patient's work of breathing. We can increase our CO2. If it's too short of a T high, we can decrease our lung protective mechanisms, and we can also decrease CO2 diffusion. Let's talk about that T low for a second. So you see down here, I'm going to zoom in a little bit. So our T low is right here in this area, and you can see we never get the baseline as far as that goes, but here's our flow waveform, and this looks a lot like the Draeger waveform, but I couldn't really find a good scalar waveform for APRV for both the Hamilton or the Draeger, and the Puritan Bennett is just pretty horrible. But here we have, you see these degrees of slope, right? Here we have a normal patient on APRV, and here we have a patient with ARDS on APRV. What happens to a patient's lung mechanics when they have ARDS? They have a decreased compliance and an increased elastance, right? So what does that mean? That means the lungs snap back a lot quicker. The lungs snap back much quicker. We have an increased elastance and a decreased compliance. This means that we have to compensate for that with our T low so we don't have that abrupt closure. So what we found in some research and some theoretical applications is that if we set our T low about 75% of our peak expiratory rate, we should have this ideal slope and this ideal amount of air trapping, okay? So that's the preface I like to work off of when I set APRV, which is rarely nowadays because clearly I'm not working clinically as much, and when I do, I'm sitting behind an ECMO pump, but I miss it. Anyway, but generally that's how I would set my APRV, and it worked really well for me. But again, all things considered, if you're air trapping too much and you're causing all these issues, and you just have to adjust accordingly. But I think it's better to err on the side of a shorter T low versus a higher one to protect the lungs. What I see oftentimes is an adequate setting of T low, and you can see it in the waveform. You can see the lung completely de-recruiting. You can see a return of, what is going on here? You can see a return of flow to baseline. And unfortunately, I see this a lot in my pediatric population. And it's very frustrating to see, especially when you are an ECMO specialist and you don't touch the ventilator anymore. Anyway, let's get into weaning. So when we're weaning our patient off APRV, we're assessing the same parameters that we would for a patient on conventional mechanical ventilation. What's their FiO2? What do they look like? What is their disease process? Is it resolving? What are our goals in care? But technically, when we're weaning them, we're going to make some adjustments, right? So there's a few methods, but I like the drop and stretch method because that's what I'm used to. There's a little bit of research behind it, and it's intuitive to me. So what we're going to look for is our T high. We're getting to a point where our T high is about 8 to 10 seconds long, meaning that we've extended our T high because the patient can spontaneously breathe and clear their CO2 well, and we've lengthened it out and got rid of a few drops, right? If we increase our T high, we're going to adjust accordingly. Everything's within the proportion. So we're getting more and more towards the level of just CPAP, right? Let me get down here. So this is where we're at. So this is where we initially are. Now we're starting to wean our patient, right? So we're lengthening our T high. Lengthening. The patient's breathing above this. We're having a few releases. We're going to still have our P low at 0. If we have to go up on our P low, this patient's probably not ready to be weaned or liberated from APRV. And if our CO2 levels are staying normal, right? So the patient's being able to support their own breath with our given support. Now what we're going to do is called drop and stretch. So we're going to decrease our P high by 2 centimeters of water pressure about every 4 to 8 hours, maybe more quickly depending on how well the patient's doing. I would rather assess more quickly than less quickly to get the patient off the ventilator. And we're going to keep increasing our T high by about 0.5 to 2 seconds. So that's a pretty big spread. So of course you're using your clinical judgment, looking at our patient, seeing what's going on, and assessing ABGs and whatnot, and all our other adjunct measurements, okay? But basically we're gonna start here, we're gonna end here, and then we're gonna pop that baby off. So once our P high is about 20 millimeters of mercury, and our stretch is about 20 to 30 seconds, we're basically gonna wean our CPAP to about 15 centimeters of water pressure. And then once we get there, we can just kind of extubate from that point. So we can extubate as high, I've extubated from CPAPs as high as 18, 20, depends on the patient. So once you get to a CPAP level, you can wean down from there and then pull the tube out and put them on BiPAP, CPAP, whatever you need to do to help them out afterwards, depending on what's going on. But this is the Habashi method for drop and stretch. Dr. Habashi is a very renowned investigator for APRV and support of APRV. So I generally defer to his research and literature when I'm researching APRV. But there's a lot of other good literature out there for APRV. Before we go on any further, I want to talk about some of the downfalls. Okay, so APRV isn't very well studied. There's a lot of cool research out there, but there isn't a lot of strong evidence as we do with conventional mechanical ventilation. And I think that's fairly obvious due to time and all these other issues. But with APRV, we have a lot of good animal data, but we don't have a lot of good human data. There's promising data, but it's just not solid evidence to make this paradigm shift for change. I think it's appropriate. I think APRV is a lot more appropriate for patients, trauma patients. That's just from my experience and a lot of research I've delved into. Some people think it works well in ARDS. I absolutely do not think so. But it could boil down to clinician experience, facility experience, the different patients individually. But APRV has issues with synchronization as well and utilization. So like I said earlier, patients are heavily sedated on APRV, which completely negates the whole goal of keeping them breathing a little bit more, using their muscles a little bit more, reducing that atrophy, and actually spontaneous breathing recruits different alveoli in dependent regions of the lungs, right? Also, when we have this release here, okay, so you got to think about it. This patient's breathing. We have this release here that's almost a forced expiration. Let's say we have a patient taking their breath in, their spontaneous breath in right here, and then our machine decides to give them a release. Well, it doesn't decide, it's time cycled. So at whatever time it cycles at, it gives a release. This patient's taking breath in. You're taking their breath away immediately right there and dropping that complete flow and causing asynchrony and causing this worker breathing issues. Often, and patients aren't always comfortable breathing like this. So the theoretical application of APRV is fantastic. The practical execution of APRV is still needs some work. There's a lot of ambiguity about the settings. There's a lot of ego and opinion about APRV settings, but that's why I try to keep it simple in this video. Okay, let's move on. That's enough beating up on APRV. We're going to cover Heliox and nitric really quickly. I don't know how often you guys and adults, this is an adult targeted course, so I don't know how often you guys are using Heliox with adults. I've used it quite a bit in the MICU for my asthmatics, but they probably should have gone on ECMO, to be honest with you. But I've used Heliox to good effect, but obviously Heliox is a less dense gas. It is a gas that's less dense than our normal ambient air or oxygen by itself, and it is supplied in concentrations of 70-30 or 80-20. Now, the thing about Heliox use is that if you have someone who's an asthmatic and they're status asthmaticus, and let's say they are on a ventilator and you're administering Heliox, as long as with whatever you're doing to treat their status asthmaticus, if they're on 100% oxygen and you're giving them Heliox, that is not doing anything for them, okay? You want to titrate your FiO2 to a reasonable level, as low as you can possibly get it without killing your patient, and then provide that Heliox if you do use this, okay? So I would target an SpO2 of 85 or higher generally. I don't have any research to back that up. That's anecdotal experience, but the physics behind it is real. You want the lowest FiO2 you can possibly have on your patients to have an effective mixture and distribution of Heliox. There's some conversion factors that we can use when we're using our flow meters. So our conversion factor for 80-20 is 1.8, meaning that it diffuses about 1.8 times faster than oxygen, so you're going to have to adjust your flows accordingly. But we can use this with patients with post-extubation stridor, but mostly with acute asthma, upper airway obstructions. You can also use it for that as well if they don't end up intubated due to the severity or the development of their upper airway obstruction. So just understand that Heliox is a gas that's not as dense as what we would usually administer. We can use it to overcome certain obstructions. It provides a more laminar flow. It's not as turbulent, and it will distribute more evenly amongst the lung. And it is relatively effective in patients with acute asthma. Here's our regulator that we'll use on our H tanks, our H cylinders. And nitric oxide, it's our next quote-unquote gas that we're going to cover. We're not going to cover any sort of anesthetic gases in this course. But nitric oxide, we all know and love it. You folks that work in CTICUs or CVICUs, whatever you want to call it, I'll use this quite often because after a lot of cardiac surgeries, you need to help that right heart out. So you'll have some milrinone, you'll have some nitric oxide on board, and you'll have a residual sympathetic tone within your pulmonary arteries, depending on what kind of surgery you had, or some sort of reperfusion inflammation going on. So nitric oxide is a viable option for a lot of your patients who are post-op cardiothoracic surgery. But basically what it does is that it'll diffuse into the pulmonary vasculature, so in the endothelium, and it's an endogenous molecule that we're giving through an exogenous means. So what we're going to do is we're going to augment our normal biological process, and we'll have our smooth muscle convert GTP to cyclic GMP, and what that'll do is cause smooth muscle relaxation. So whenever you see stuff like that, with at least GTP to GMP, we're thinking of relaxation. But it's a selective pulmonary vasodilator since we are inhaling it, right? So if we're inhaling it, it has to get to, if we have a blockage, atelectasis consolidation or anything like that, that gas isn't going to go to the capillary bed. It's going to go to the areas that are perfused and ventilated, so where we have a normal VQ. We generally start our dosages at about 20 parts per million for a normal human being. Dosages higher than that are usually utilized in the cath lab to determine responsiveness in situations where we're diagnosing primary pulmonary hypertension, which we discussed earlier in this course. Common side effect of nitric oxide administration is methemoglobinemia. Okay, I'm sure you've seen your methemoglobin rise a little bit, some small percentages, but that is a common side effect, and it's more pronounced when patients are taking drugs that will promote the development of methemoglobinemia, like a corticosteroid called dapsone. We have a few side effects, and these are actually on the module themselves for the nitric oxide delivery, and we're looking at nitrogen dioxide. So nitric oxide will interact with oxygen to develop nitrogen dioxide, if I can speak. And so basically patients who are on high FiO2s are more likely to develop higher levels of nitrogen dioxide. So we have to be aware of that because it is an oxidative and a dangerous molecule in our body, and we should not have that in there. So I never really had any issues with that, but you can definitely, it's a readout that you get on your machine and you can monitor for. But methemoglobin is an interesting phenomenon of nitric oxide administration. So basically we're oxidizing the iron in our hemoglobin to cause methemoglobin, which is not really effective as far as our delivery of oxygen. So we're going to assess those levels. What would you do if you saw an elevated methemoglobin level? That's my question. Would you administer methylene blue or would you stop your nitric? Titrate your nitric down. I would titrate my nitric down and see where it goes from there, because that might actually promote a quicker wean from nitric oxide. Okay, that's it for the gases. Let's talk about the oscillator. I probably should have moved this up to the APRV section for a smoother transition, but we're gonna knock this out as well, because using the oscillator, it's kind of a lost art, and I think it could be effective, but in the world of ECMO and everything else, it's becoming far and far less used. But I will say I have had a patient on the oscillator and ECMO. I've had a patient prone and on ECMO and on the oscillator. So there's a time and place for everything, but I'm not sure how experienced everyone is in this course with the oscillator. So I tried to make it as simple as possible. This is an adult-centered course as well, so my pediatric RTs probably have more experience with HFOV versus our adult respiratory therapists. But let's just break it down, keep it real simple. So the oscillator, if you look at it, it looks like an ancient machine, right? You don't have any waveforms, you don't have anything like that. You have your maps, you have your frequency, you have your amplitude, you have your bias flow, you have your I time percentage, and then you have your FiO2. You have your alarms, of course, as well. So in a way, it looks intimidating, but it really isn't. You can set things fairly directly, but you have to understand what you're affecting with each thing, as with a normal ventilator. So let's talk about our maps, or mean airway pressure. So if you're switching someone from conventional ventilation to the oscillator, it usually depends on your hospital protocol, but generally we're going to increase our map on our oscillator about 5 centimeters of water pressure above our conventional map. So if we had a map of 25 on our ventilator on pressure assist control, we're going to have our map set at 30 on our oscillator, okay? Now our hertz or our frequency in adults, we generally start lower than we would in pediatrics, okay? So when I say start low, and this is just a protocol I've always worked off of as long as I've been a respiratory therapist, we're going to start at 6 hertz, okay? Now the way hertz is defined is that it's instead of breaths per minute, think of it as breaths per second. So if I set my patient at 6 hertz, how many breaths per minute am I giving that patient? I'm giving that patient 360 breaths per minute, okay? The goal of the oscillator is to provide as much like distension and oscillatory, this is the easiest way to say it, oscillatory demand or supply as we can to protect our alveoli, okay? The more shaking we have going on, we have the more distribution of gas, we have the more efficient opening of our alveoli, and the more protective mechanism within our alveoli, because they almost self-regulate. We'll get into that a little bit later. Now our hertz are kind of counterintuitive, so I keep referring to our hertz or frequency as our breaths per minute. Now it's counterintuitive, and you guys probably already know this, but this is good for just future knowledge. If you have an increase in your CO2, you're going to decrease your hertz. Okay, you're going to decrease your respiratory rate. If you have a decrease in your CO2, okay, so that gives you some wiggle room, right? You're going to always increase your hertz. So ideally, you want your patients with the highest hertz you can possibly provide with the appropriate level of hypercarbia. Now, we're going to accept permissive hypercarbia in this situation as well as APRV. I left that part out. So let's talk about the amplitude. So the way we judge amplitude is from the clavicle to mid-thigh and if the body's wiggling, okay? I'm going to leave it at that for the purposes of this lecture. I'm not going to give you any numbers, not going to go out anything like that. But let's talk about what our amplitude's doing. So our amplitude is in effect our tidal volume. If you think about amplitude, if we increase our amplitude, we're going to increase our expansion, right? So if we increase our amplitude, we're going to increase our CO2 clearance. So if you get an ABG back, they're hypercarbic. If you can, try to increase your amps instead of decreasing your hertz, if it's possible. If you're hypercapnic or your pH is a little bit low, you can decrease your amps and maybe increase your hertz. So those are things you kind of can go back and forth. So just switch things around. Your amplitude would be like your respiratory rate if you want to think of it in a conventional sense, and your hertz won't be anything normal, but it basically changes directly with your changes in CO2. Now this also has an effect on our oxygenation, but we really want to focus on our MAP with our oxygenation, so we can always increase our MAP as long as we're staying in safe ranges to improve our oxygenation, because we want to keep those alveoli open and oscillate around a certain MAP. I'll show you a waveform in a second. Our bias flow is what's going through the circuit, and generally that's set and forgotten. But if you're backed against the wall with your MAP, sometimes you can increase your bias flow and you'll get you will have an increase in your MAP. So that's something to consider as well. You should rarely ever have to change that. Now your eye time percentage is usually set at 33%, but the other option you have two options, it's 50%. Now why would we do this in adults? Well, this can occur in situations where you have issues with CO2 clearance, right? Again, remember, we have a lot of other options before we do things like this, but if we change our eye time percentage from 33% to 50%, it improves our CO2 clearance, okay? It increases our duty cycle for the oscillator, and we're able to somehow get out a little bit more CO2. Not somehow, but it's really not that effective. I've never had to do it without changing other things. There's one more last-ditch resource that people usually use if they have issues with hypercapnia on the oscillator, and that's deflating the cuff, so we have an air leak. But again, if you think about it, that kind of defeats the purpose, right? And then finally, we have our FiO2 that we can adjust up and down. So I think that's pretty straightforward. This is kind of the physiology behind the oscillator and the waveform that we would generate if we had a way to look at the waveform on the actual the oscillator. So here we have our mean airway pressure, and what we're hoping to do is oscillate around our mean airway pressure and provide that support to our alveoli. So you see here we're oscillating between a range of about 30 centimeters of water pressure, and we're going down to a low of 10 centimeters of water pressure. But we're always maintaining, we're always staying recruited. If I had a pressure volume loop here, we would always be kind of in the middle, right between our pressure volume loop. So here's a conceptualization of our amplitude and frequency and how these things interact. Now, if we increase our amplitude, we're increasing this wave, right? We're increasing this wave up to here, and we're going more down to here, and that's effectively our tidal volume. Now, our frequency, if we increase our frequency, we're going to squeeze this down, right? And we're going to have less time to get rid of CO2 and a little bit more air trapping. So that's why our CO2 will go up. But we're also providing a better mean airway pressure with that. So if you decrease your frequency, you're going to have a less effective protective ventilatory strategy on the oscillator. Okay? So a decrease in frequency, like your respiratory rate, is going to improve your CO2 clearance, actually, because they're squishing this down. So if we have an increase in our frequency, we're going to increase our CO2. If we have a decrease in our frequency, meaning we have more of these revolutions or oscillations about the mean airway pressure, we're going to decrease our CO2. But we want to understand the physiology behind this, okay? And this is what we're going for right here. You see with conventional ventilation, we have these major pressure swings up and down, and it's almost inadequate throughout the entire the entire breath cycle. When we have someone with ARDS and they're extremely atelectatic and they have a low compliance and high elastance, you want to maintain this here because your lungs are going to shut down much quicker. Okay, that's in theory. So the problem with the oscillator is that there's actually been studies that shown that it increases mortality rates, the Oscillate trial and whatnot. And that kind of ruined the reputation of the oscillator, but you always have to understand clinician experience when we're implementing these strategies. And this is in adults. We're not talking about kids. Here's a quick representation of how we're actually moving gases in and out of our lungs. So you look at here, you're like, how is anything getting in and out of our lung? Well, there's a lot of physics behind it. And there's things like called Taylorian dispersion. So that's going to be around our radial mixing right here. And we're going to have some convective streaming. We're going to have our normal turbulent airflow. But what you have to think about is that if we're shaking things around, our molecules are constantly moving, right? Molecules of CO2 and oxygen and whatnot. And these oscillations are being attenuated when we go further down these bronchial tracheal generations. So when we get to our normally aerated alveoli, we have a much dampened oscillatory waveform, right? Because there's more compliance here. But when we get to our atelectatic alveoli, we have the oscillations actually working to recruit and open these alveoli up in this sense. So we're not actually imposing these stresses on this healthy or open alveoli. I won't say healthy. We have some collateral air movement with the Pendeluft, so that's German for swinging air. That goes back and forth, so this will probably go to an area of least resistance, right, and fill this up, and then we'll have some air moving up and out. Our radial mixing refers to our Taylorian dispersion, where we have a higher velocity of air on the bronchial walls versus a higher velocity of air in the middle of the bronchial versus the sides. So the sides, think of it in theory, are moving out. The insides are moving in. And so we have gas exchange going out through the outsides and in through the middle. It's the easiest way to explain it. We also have some collateral ventilation through some normal anatomical fistulas that are associated amongst the alveoli that help things move in and out, okay? So basically we shake in, and on the sides we're shaking in and the sides are sliding out. That's the easiest way to think about it. All right. So let's slow this down a little bit, break it up some. We've been going for quite a while. We're halfway through this. So let's start with a case study. So a 42-year-old male with a past history of hypertension. The patient presents to the ED with a complaint of respiratory symptoms for approximately 5 days. He has worsening shortness of breath and abdominal pain. The patient goes into sudden cardiac arrest. All right. Respiratory symptoms for 5 days, shortness of breath, abdominal pain. History of hypertension. His TTE revealed moderate pericardial effusion with suspicious tamponade. Intubated and transferred to the ICU. He received multiple blood products for persistent coagulopathy, placed on conventional mechanical ventilation, continuous mechanical ventilation, but requires extreme settings to support oxygenation and ventilation. 3 days in, he gets placed in the oscillator. There's another issue with the oscillator. The later you implement the oscillator, the worse the outcomes, just like anything else. But that's another issue with some of the studies that are out there. So we put on the oscillator, his MAP is 38, so we could assume, based on what I said, right, just in theory, that his MAP on the ventilator was 33. Hertz of 5, amplitude of 105, and an FiO2 of 100%. He's been placed on continuous renal replacement, so CRT, due to worsening lactic acidosis and anuria. So his kidneys aren't working, he's not perfusing them. He's in cardiogenic shock and he's on the oscillator. That does not sound like fun. You have to understand the oscillator is going to put a significant strain and reduction on your heart, a reduction of venous return and increase in afterload on your heart. So somewhat increase in afterload, but it's not a good idea to place a patient in cardiogenic shock on an oscillator, because actually what you do when you put someone on an oscillator is actually we're going to fluid bolus them and kind of top them off to make sure that they can stay hemodynamically stable when we make this pressure change. So his blood pressure is 90/50. He's on a lot of vasoactive drugs. Would you recommend this patient for ECMO? What type of ECMO support would you recommend? So we went through the oscillator. Pretty much how it works nowadays with the oscillator. You're going to probably transition to ECMO at some point. Probably should do one or the other earlier, but we're not going to go there. So this patient's in cardiogenic shock. He's on a lot of vasoactive drugs. Would you recommend him for ECMO? Based on his oscillator settings, absolutely, I would recommend him for ECMO. There's nothing good going to come out of this, and him in cardiogenic shock is just it's going to end in death. Might end in death on ECMO, but who knows? So the key word here is cardiogenic shock. what kind of support would you recommend? So ECMO, we have VV and VA ECMO, veno-venous ECMO and veno-arterial ECMO. So what is ECMO? So ECMO is basically an invasive technique. We drain the blood from the venous system and we pump it through the other side. It'll be through an artificial lung generally. The difference between ECMO and maybe a VAD was we're not generally using an artificial lung, but you could have an RVAD and an LVAD with an oxygenator, and it's essentially VA ECMO. I'm not going to get into that. But what we want to do is support organ function in patients with cardiorespiratory failure or respiratory failure. So essentially you want to bypass the lungs or bypass the heart, right? And do it bedside and keep it nice and clean. So let's talk about some indications and contraindications of ECMO. This is a very gray area, and I would call everything a relative contraindication, all right? Oftentimes you'll hear things, people say that people with a malignancy or their decline in their health status is related to a malignancy or a malignant event or a progression of some sort of cancer, that they shouldn't be on ECMO. I've seen that oftentimes not the case, and I've actually seen some good cases come out of it, and it's very sad to think about because there are patients who are denied ECMO because they have some sort of transient issues with the progression of their cancer that maybe overwhelmed them metabolically, who knows, but they haven't been offered ECMO and they died. And I've had patients who had cancer or some sort of transplant rejection that they probably shouldn't have been offered ECMO, but they were offered ECMO and they lived. You can never say anymore. Age is usually a relative contraindication. I think obesity used to be one. But at this point, I don't feel confident in telling you guys absolute contraindications. I'm going to tell you, you're going to see everything and anything cannulated these days. So just be aware of that, okay? And I'm going to leave this slide at that. Defer to your experience because, like I said, I can't pinpoint really true issues. Sometimes when you have severe cranial bleeds, which again, I've also seen people place an ECMO with that, that would be a pretty big contraindication. Aortic dissection would probably be a pretty big contraindication. So it's all relative. This is a horrible slide and I apologize for this. I'm trying to use more pictures actually and just kind of go through it, but we discussed earlier in this case study, would this patient go on VV ECMO or VA ECMO? So basically with ECMO, we put a large bore cannula into some sort of vessel, a big vessel, a central vein. So it could be the IJ, it could be in the femoral vein, the femoral artery, it could be in the right common carotid artery, it could be in the subclavian, depending on how you want to configure these things. It can be centrally located, so you can have it actually your chest open and into your either right atrium or IVC, and then subsequently into the base of your aorta. So it all depends, and we'll talk about that in a second. But we have an oxygen air mixture that's passed through this oxygenator that's a very porous membrane that has an incredible surface area like our lungs, and it's very efficient. It's very efficient at getting carbon dioxide out of the blood. So we do that by means of an oxygen flow meter. And when you hear the term increasing the sweep, that's what we're doing. Generally, when people are placed on ECMO, you have a sweep to flow ratio of 1:1. So if you have someone on a flow of 4 liters per minute, we're going to generally have our sweep as initial settings, like we do on the ventilator. And that means that we're going to look at our ABG, see what our CO2 is doing, and adjust our sweep accordingly. Depending on your protocol or how you do it, you can adjust the sweep in increments of a half a liter, or even with the pediatrics, you do a quarter of a liter. What's happening is that we have VV and VA ECMO. So basically what the last part of these statements mean is where the blood's being returned. So where we're pulling blood and where we're returning the blood. So VV ECMO, we're pulling blood from the venous side of the system and returning it back to the venous side of the system. VA ECMO, we're pulling blood from the venous side of the system and returning back to the arterial side of the system. VV ECMO functions to augment gas exchange. It doesn't necessarily help right heart function at all. It actually can hurt right heart function depending on the situation. VA ECMO provides a little bit of lung support, but it functions in its highest capacity as cardiac support. And this is a misnomer when we talk about lung support. Not a misnomer, but sometimes a misinterpretation. It does provide some lung support, but actually, if you have a patient who has cardiogenic shock or has some sort of cardiac issue where their heart is not working anymore, and then they subsequently maybe develop a pneumonia and ARDS, VA ECMO is not going to cut it as far as providing their circulatory support. And I'll explain that in a little bit. But it's commonly misconstrued the fact that, oh, if we can't figure it out, put them on VA ECMO. That is not the case. Here are some examples of pump components. Now, a lot of these examples are from a machine that's called a CardioHelp. There's other machines that I've worked with called the Rotoflow. There's a bunch of other things out there that you might see, the CentraMag, but generally you'll see the CardioHelp, and it's a pretty simple machine actually. So here we have our air oxygen blender, okay? So this is essentially our FiO2 on the pump, right? Right here is our sweep gas manipulation. So here's our flow meter for our sweep gas. And over here you can see these small increments. And oftentimes we can use these to titrate our sweep gas with our pediatric or neonatal patients. You can see here this guy's sweep gas is set at about 3 liters per minute. His FiO2 is at about 100% on the air oxygen blender. Right here is our HLS system, or our oxygenator, and here you can see it's nice and red with blood here. I can't really get up close to it to see some sort of abnormalities with it, but oftentimes we'll look in this area because there's a lot of turbulent blood flow, and it slows down a little bit. And we can develop some fibrin shredding and clots, and that will subsequently lead to oxygenator failure. We measure pressures on our venous side and arterial side, and through our manifolds and everything else over here. But you see right here, this is our circuitry. So this is our venous blood coming back, or deoxygenated blood coming back to our system. It's going to go through our centrifugal pump and then out our oxygenator and back to the patient as bright red, nicely oxygenated blood. Here you see this pigtail here. This can be used for air emergencies. We can aspirate air out of the oxygenator if we happen to entrain air into our venous side of our system. Here you see our circuits again, and you can see our arterial circuits labeled as red and our venous circuits labeled as blue. Now, when we say arterial and venous, we don't mean VA ECMO necessarily. Arterial is always meaning we're returning oxygenated blood back to the patient. That could be in the venous side of the system if it is VV ECMO. Here you see sensors. So there's various sensors that sense flow, SVO2, SaO2 levels on our circuitry and our blood. There's safety mechanisms built into certain machines. So for example, this CardioHelp is going to have a air bubble sensor that's going to be on our arterial limb. So what that means is that if it senses an air bubble get into our arterial limb, which means that it goes back to our patient, which could be detrimental, it will shut down the pump and stop flow, and you'll subsequently clamp the circuit off and aspirate air out of here if you can. Worst case scenario, you change things out, which is not fun. But anyway, these provide safety mechanisms. They also provide parameters that are shown on the screen. Hopefully I have a picture of the screen. I don't think I do. And it'll show your flow rates. It'll also show you your delta pressure. So you always want to know what your pressures are between this area and other areas throughout the system to gauge the health of your circuitry and your system. So for example, if you have a certain pressure going into here and you have a certain pressure going out of here, so let's say this pressure is higher than this pressure, then you might have an issue with your oxygenator. Subsequently, if you have an increasing negative pressure over here, you could have some sort of obstruction, or your cannula might be suctioning against the wall of the vessel over here if you have a very high negative pressure because we're sucking that blood in. Or you can be a little hypovolemic, or you might need some fluid resuscitation or blood, or so on and so forth. So here are some of the components of our ECMO circuit. This is generally with the CardioHelp. Right here, I don't think this is necessarily the CardioHelp, but sometimes we'll have an extra pump that we'll use in emergency situations, and we'll use a hand crank to use that. Here are our cannulas. They're kind of hard to see here, and it's hard to make cannulas interesting. So I just have 2 pictures here of some cannulas. So here is our general configuration, right? So here are our venous cannulas, and here are arterial cannulas. And all I want you to note here is the difference between the two. So here you see that our venous cannulas are longer. You can't see the different holes. You kind of can, but there's different holes on arterial versus venous cannula, and that's due to their actual mechanism of functioning. And our arterial cannulas are shorter, right? Because we want to deliver a shorter return device for less resistance. But what we want to know about ECMO is that, or what we need to understand about ECMO is that a lot of our flow, or all of our flow, is limited by our venous cannula and our venous system and what's going into the pump. These pumps are preload dependent and afterload dependent. So meaning that they can adjust based on preload and afterload. So Our flow is very important to determine our output of the machine, just like our heart. Whatever goes back to our heart needs to come back out. If it can't get there and get to the left side of our body, we can't perfuse. This cannula over here is a dual lumen cannula. This isn't necessarily what's called an Avalon cannula. There's different brands and types. There's an Origin and there's all other things. But what you need to understand about this picture is that we can often use a single cannula. And what do you think are the benefits of using a single cannula? You have less insertion sites, you have less chance for infection, and so on and so forth. This would be in a VV configuration. So what you would do here is you would insert this cannula into the patient's IJ, you'll go down into their IVC, and you will situate it there and target or point one of these ports at the patient's tricuspid in the right atrium. All right, so what you're having is you're sucking up blood, deoxygenated blood, it's going back to the pump, and you're being reinfused with your oxygenated blood, and it'll come out this way into your heart, okay? So patients with these kind of cannulas can walk, they can rehab, they can do a lot of fun stuff, but they're expensive, and the placement's somewhat difficult. So sometimes often you do need fluoroscopy to insert these. These cannulas are usually inserted peripherally, as is that, but this can be in your IJ, and you can have a return into your fem vein right here, or we'll get into that in a second. But these generally can be inserted with ultrasound or actually just percutaneously as if you're inserting a central line. Here's our beloved equation for our flow. And what we have to understand with any sort of cannula that we put into our body, be it an endotracheal tube, an IV, or a central line or anything like that, we have to understand the physics of flow. We have to understand that if we increase the length, we're going to increase resistance. If we decrease the radius, we're going to increase our resistance. And this is true for our cannulas. So what you want when you're setting your patient up on ECMO is the shortest, fattest cannula you can throw in there, okay? And that's with respect to the cannulation configuration. Here's an illustration of VV versus VA ECMO as far as configurations go. Right here we have a central cannulation, so we can cannulate centrally or peripherally. So centrally, this will go directly into an open chest and directly at the heart. And there's many benefits to each configuration. I don't think I have enough time, or I don't want to make you guys pull your hair out trying to explain all these things, but I'll do my best to kind of just give you this basic knowledge. But central cannulations are very effective for patients who are undergoing cardiothoracic surgery, heart surgery, and they're going to go back to the OR, right? You don't have to open up their chest again. You're directing. So you see right here, this arterial cannula is going to give blood directly back to the base of this aorta. We're going to pull blood from our right atrium or our IVC, depending on our configuration, okay? And this is for patients with cardiogenic issues. Now, if you look at VA ECMO over here in a peripheral configuration, we're returning our blood, let's say in our fem artery, and we're pulling from our fem vein. Which way does blood flow? Well, blood flows this way. So what happens here is you're pushing blood in a retrograde fashion to our left atrium. What could that do? Well, that can cause a lot of strain in our left atrium and left heart. If we have an already compromised heart that's pumping against this, 4 liters of flow coming back at them, you can have LV distension, and you'll come into situations where you have to actually put an event in there to decrease the pressure in that heart. This can be counterproductive for cardiogenic support and recovery, for example. Here we're giving blood right back to the base of the aorta, and we're actually promoting this antegrade flow into our normal circulation. Now, VV ECMO here in a single cannula is kind of what I just spoke about with this double lumen cannula up here. We're going to put this into our IJ, internal jugular vein, and we're going to pass this down into our IVC. We're going to pull blood from our IVC, and we're going to dump it right back into that same cannula into our right atrium, okay? That oxygenated blood. Issues with this is that we have hepatic veins that this can get lodged into and cause some flow issues. You can also perforate the heart, which I've seen happen a few times as well, with the misplacement of this cannula or when the patient's moving around. Here's another illustration of vascular access that you guys can refer to. I think that I kind of beat this to death a little bit, but here we go in this configuration right here. We have an IJ-FEM combination here. So we have this long cannula going up our femoral vein. and is pulling blood away from the patient, and we're returning the patient into our SVC, right into our right atrium, and it's going into our systemic circulation. The issues you'll find here is if this cannula and this cannula are too close together, you'll suffer from something called recirculation issues. So we'll be pulling this oxygenated blood away from the patient, and you'll have issues with your saturations. In this configuration here, we have a FEM-FEM configuration and VA ECMO. So here we're pulling from our IVC, and then we're returning the blood back to our left femoral artery, and it'll return back to here. What's happening in this situation, you see this is all blue? What's happening in this situation is that you still have native cardiac flow, right? You still have blood going from the right side of your body to the left side of your body. So if you have dysfunction in your lungs and you're on VA ECMO, this blood is going to be returning to the left side of your heart. Now your aorta branches off into 3 different sections, right? You have your carotid and everything else going on up here. So what happens is that it selectively perfuses your subclavian and your carotid arteries, where you develop what's called a north-south syndrome or Harlequin syndrome, where you have deoxygenated blood going to your brain and your upper body, and then you have oxygenated blood going to your lower body. So we don't want deoxygenated blood going to our brain. That can happen in this configuration if someone has lung disease on top of their cardiogenic shock or cardiogenic disorder. Here we have our... it looks to me like an IJ and this is actually the same single cannula, because sometimes you can put return into the carotid artery, but that's usually reserved for the infants. Here we have our central cannulation, which you see is directly right into the heart, which is pretty intense. So let's talk about the real world. It's not pretty. So here are real world cannulation sites. Hopefully you guys have had a chance to see these things in your hospital. Some of you guys at small hospitals will never ever see this, so I hope this isn't too much, but I think you guys should all be exposed to this. So here we have our FEM-FEM configuration. Now this guy is on VA ECMO. And the reason I know this is, one, because of this right here, this reperfusion cannula, or this reperfusion tubing. So if you put a cannula into someone's femoral artery, blood flow still has to go this way, right? Well, you're putting a big old cannula in there, so can it really go down there? Sometimes we have to monitor for this and check Doppler pulses in the feet and understand, see if we're perfusing the feet. Oftentimes you'll see it turn blue. This cannula is providing antegrade flow to the distal areas of the leg to provide that oxygenation in lieu of this cannula. Right here you have your baby. So here is going to be a cannula going into your right common carotid artery for this child. They ligate the artery above because they have enough collateral circulation for the brain. And here you see this configuration is called VVA. So you have, what happened here is that this baby was converted from VV ECMO to VVA because it developed some sort of cardiogenic shock. So here we have venous blood being pulled out of our dual lumen catheter. This is kind of beyond the scope of what we're doing. And being returned to augment this patient's flow and cardiogenic support or cardiac support to the right common carotid artery. With this configuration, you're going to have your antegrade flow, and you're not going to have that many issues as you would with a FEM-FEM configuration. Now here is an example of what you would see with your central cannulation. So a whole lot of nothing. There's a ton of packing, there's a ton of wound care that needs to go on that we participate in. But here you have your venous cannula that's either going to your RA or down to your IVC. Pulling blood out is going to return it right to the base of this woman's aorta. So they're nasty sites. We've got to keep them clean. And they're very intimidating when you're first dealing with them. All right, so I talked about VV ECMO and VA ECMO. Now let's make it even more confusing. So you have alternate cannulation strategies that are evident here that aren't conventional as far as your VV or your VA. You have VVA, you have VAV, you have VVAV, and you have VVVA. And you can probably figure out 10 different more cannulation strategies, but these are some common ones you'll see. So let's start with VVA. So here in VVA, you have your normal VV ECMO circuit, right? But this patient had to be converted to VVA ECMO, maybe due to some sort of cardiogenic shock. So what happens here is they put another cannula into their femoral artery, and they're going to wire these pieces together to suction through the pump and then get returned here for cardiac support and systemic perfusion. So VVA, pulling, returning. Here we have VAV. So in VAV here, this was what you would resort to if you had developed that north-south syndrome or that Harlequin syndrome, as I discussed. So what's happening here is that this patient, well, there's a few ways this could have happened. So this patient was either on VV ECMO or VA ECMO. I'm assuming VA ECMO in this case. So this patient was cannulated fem-fem for VA ECMO. And what happened was they developed some sort of pulmonary issue where deoxygenated blood was mixing into their circulation, and they developed north-south syndrome. So what's happening now is that this circuit was wide in and introduced into their IJ. So now we're returning oxygenated blood into their right atrium, and we're also returning oxygenated blood into their systemic circulation. But this blood is going to go through their pulmonary circulation to augment our cephalad directed circulation. Okay, so you'll have this configuration north-south syndrome. VVAV is a whole nother mess here. So in VVAV, we're pulling quite a bit. Okay, so we're pulling from two areas of our venous circulation. So we're pulling from our IJ and our fem vein, and we're returning both in our IVC, returning oxygenated blood into our IVC, and we're returning oxygenated blood into our systemic circulation. This is another configuration that's available for patients with north-south syndrome. And we have VVVA. VVVA is exactly what it seems. We're pulling from all these venous cannulae. So we're pulling from our IJ, we're pulling from our SVC, IVC, and we're also pulling from our fem veins, and we're returning all of this blood to our systemic circulation. So this could be someone who needs a lot of flow. Now, finally, we also have a VVV configuration. And this configuration is often seen in patients with sepsis, so we have to actually put another drainage cannula because we are flow limited. Flow returning back to the pump is the most important part. So we have to insert another cannula into, let's say they're fem IJ cannulated. We have to put another cannula into another fem vein, pull from there, and then dump that blood into the right atrium to support that high cardiac output in sepsis. And that oftentimes happens. Whew. All right. There's a few adjunct mechanical circulatory support devices that we use in ECMO. I'm just going to briefly touch on this so we don't kind of get more confused and muddled. But you can have VA ECMO and you can have a balloon pump in, which is actually often used, and it's been found to actually have better outcomes in certain cases. You can have an Impella device put in, and you can have a tandem heart. I haven't worked much with the tandem heart, but the Impella, what we do here is the Impella goes in here, and it's going to help reduce LV distension with our retrograde flow. Okay, so instead of putting a vent in there, it acts as a vent, and it will kind of propel blood out of that area into the aorta and augment this antegrade flow in respect to this retrograde flow. The balloon pump is going to help augment our cardiac output as well and provide a source of rest. We're going to leave it at that, but we can have ECMO here with the balloon pump. So during diastole, our pump is filled up. We have this retrograde flow, so blood's building back behind it. And then we're also having better perfusion to our coronaries here. This will release during systole. And you'll have your antegrade blood flow here. So you have your reduction of afterload coming out here, and you'll actually reduce your mixing cloud to this area if there is one. So the balloon pump kind of gives your heart a little bit more rest and reduces that LV distension, and you might see this in your hospital as well. But generally people like sticking more cannulas in. All right, let's talk about management after all that nonsense. So management can be comprised of many different things. It depends on what mode of support you're on. So VV ECMO, management of hemodynamics can get you some places. So let's say you're hypertensive or hypotensive. So you want to give fluid and augment that preload that you're getting with your pump. With VA ECMO, inotropes are your friend, and so are vasodilators and vasoconstrictors, so antihypertensives. If you're on VA ECMO and you develop hypertension, you're going to have an increased resistance in your output, just as you would with your heart. It functions the same way. Ventilator management is something that needs to be discussed, and it's research I've been pushing for years now. I really want to develop a study looking at the actual effects of quote-unquote rest settings, which there is no consensus on, and ECMO pump times, mainly with VV ECMO. So oftentimes the lungs are neglected with ventilator management. So I suggest that we maintain our normal ventilatory parameters in a safe range and assess for weaning and see if we can get them off the ventilator faster. And this is especially true for VV ECMO. Conversely, you can actually have people off a ventilator and talking on ECMO. So a ventilator isn't always necessary, to be honest with you, depending on the situation. So for our cardiac patients, this could be the case. We've actually had ECMO patients, lung transplant, people, on VV ECMO, pending lung transplant. So being able to walk around, do this and that. So the ventilator isn't always necessary. We want to have our patients adequately sedated, even though I just said we can exercise them. Our very, very sick patients, any sort of increase in blood pressure or sympathetic activities, so can affect our pump flows. And agitation, moving around, you can affect your pump flows in that sense with cannulation dislodgement, cannulation movement within the vessel. It's really not a good thing to have. And when we have a lot of suck down or vessel damage, we increase our risks of hemolysis. We always want to be cognizant of our blood volume, so we'll monitor our eyes and nose, make sure that if a patient's being diuresed or we're managing CRT, making sure that we're appropriately documenting their eyes and nose and not letting them get too fluid negative, because you can have metabolic consequences with that. Making sure that their hematocrit and hemoglobin are adequately supplied. So we're often going to look at our CBCs, and we're obviously going to look at our CMPs or Chem10s, whatever you want to call them, and ABGs. But I feel like our CBCs tell us a lot more than our ABGs in these cases. We have so many monitoring parameters that an ABG it's good for your CO2 or whatnot, but we always want to know our hematocrit or hemoglobin depending on what your institution titrates on or unit. It can be institutional as well. But generally you want to keep your hemoglobin above 7 grams per deciliter, and you want to keep your hematocrit generally above 30%. So usually administer PRBCs pending that goal. You also want to look at, we're going to leave that alone for a second. Temperature regulation is very important with ECMO. You have a lot of their blood outside of their body, meaning that it needs to be heated. Okay, so we have to maintain the patient's temperature. We have to maintain normal physiologic range for their blood. Too hot, if we make their blood too hot with our heater, there's a heater in the ECMO circuit, we can cause hemolysis and damage of the red blood vessels. Too cold, you can induce coagulopathies. So we have to look at these things as well. We also have to pay respect to the patient as far as their actual body temperature is going. So if they're febrile, this is going to change things quite a bit. So we have to be cognizant of maintaining an appropriate temperature range. Renal nutrition management, we're definitely going to have to look at their Chem10s. We're going to have to look at their metabolic processes, metabolic outputs, and maybe suggest cutting a hemofilter into the ECMO circuit, or managing CRT with adjunct devices. We want to keep our cannula sites clean. We want to keep an eye on potential developments of infection, new elevations in the white blood cell counts, leukocytosis, obviously, that's what I just said, lymphocytosis. And keep an eye on that as well, because we're going to be introducing these microorganisms into the patient with this invasive technique. Positioning is very important. You can prone a patient on ECMO, but mostly this is very important with little babies. I've had to actually sit there with a baby on my hand for hours on end just to get things right with this cannula and get things situated, because the pump kept cutting off. But with adults as well, so neck positioning will have a major effect on sometimes the flow. But you also have to look at other parameters such as their fluid status if you're having such a serious effect on the patient's positioning with your return flow or your pump characteristics. This can also be representative of the movement of the cannula, and we have to get that assessed as well through some sort of ultrasound or Doppler. This is similar if we compare this to our endotracheal tube management, right? So we're very cognizant of these changes on our ventilator. It's the same thing with these with an ECMO circuit. Anticoagulation is a very controversial topic. In our ELSA guidelines, it basically says whatever your hospital says. It depends on what you're dealing with. When you're dealing with kids, anticoagulation is much different because they haven't developed the clotting factors that adults have. In adults, depending on what you're doing, we're going to administer unfractionated heparin, right? You have low molecular weight heparin, you have unfractionated heparin. We're generally using unfractionated heparin. Some institutions are moving more towards bivalve, but that's a whole other conversation. But we're looking often at our APTTs, ACTs, PTs, but a lot of times institutions look at ACTs, which I think is a very unreliable measurement mechanism for therapeutic anticoagulation. You can also look at what's called an anti-10A, which is a serum level that represents heparin binding and inhibiting effects of heparin on activated factor 10. So I often use APTT, or that's called your HepCore, or your anti-10A. That's generally what I use to titrate my heparin. Usually use a nomogram or a sliding scale when you're titrating your heparin. And if it's between a certain level, you'll go up on units or down, okay? Some patients with coagulopathies like sepsis will go into DIC, and DIC will affect your pump, and you'll have a decrease in your platelets, a decrease in your fibrinogen. All your clotting factors will be out of whack, and it'll be very evident within the pump and the patient. You can employ CVVHD, or what's called SCUF as well. The SCUF and CVVHD are not the same thing, into your ECMO circuit. So here's a fun diagram of how you can do this. You can literally cut a hemofilter in your circuit and administer dialysate or pull fluid off. This is a picture from my workstation at a hospital I worked at. I'm not going to give a specific name. And in this specific unit, we manage the SCUF and CVVHD, or when we're giving dialysate to our patients on our end. So the RT is doing this. So here you see a bunch of Alaris pumps, and here you see a bunch of bags of dialysate. So we're generally changing these bags based on their potassium concentrations, but this is all going into our ECMO circuit, and we have this going into our hemofilter like this, and we're pulling off fluid into our effluent bags down here, and we're measuring that. All right. It's scary. It's a lot of stuff going on. This is because this physician specifically does not want to work with renal, so we do it ourselves. We can also do what's called SCUF, which is called slow continuous ultrafiltration. So if you have a patient that's very fluid overloaded, you can put a hemofilter in line and literally just pull fluid off the patient by means of convection. So basically we're not giving any fluid and we're not taking any solutes out. We're literally just pulling off fluid. Whereas with CVVHD, we're removing fluid by diffusion, and we're also moving solutes. So those nasty cytokines and other small proteins, medium to small proteins, out of the body into our effluent. Here's some fun facts down here that I think might be just over the top for you guys at this point with all this information. But basically, we can SCUF, we can do CVVHD, we can do a bunch of other things. We can put it in line with our PrismaFlex or NextStage, whatever you use at your hospital. And we also have to be cognizant of our connections. So you see how everything's post-pump here. If you put it pre-pump, you have a lot of negative pressure going in, and you have a lot of risk of air emboli and all these other issues occurring. The hot topic with ECMO are utilization outcomes. So basically, there's argument that ECMO really hasn't changed outcomes, but basically we can argue that with ARDS as well and RSNet strategy. So it's hard to argue at this point, but here's some numbers that you guys can kind of refer to maybe in your conversation with your physicians or with other providers. Just have a general idea of what your patient's on ECMO for and what we can expect. But you can see for the most part, you get about a mid-range of survival, but except with status asthmaticus, where you have a 79% survival rate. There are many complications associated with ECMO. You guys did a discussion forum, and I wanted you to explore these ideas because it's not a fix-all. It really isn't. And sometimes we jump to this way too soon. I feel like at Duke where I worked, it was a big ECMO center, but we really only used it when we had to. But again, sometimes we probably should have gone to it sooner. I could think of an asthmatic patient that I really wish we put on ECMO sooner. She was okay, but still, it could have ended differently. But we can induce coagulopathy. So a lot of our ECMO patients, like I said, are septic or have some sort of coagulopathies occurring. Introducing these cannula, introducing heparin, introducing all these things can cause worsening coagulopathies, and we can also expose them to the risk of venous thromboembolism. So introducing them to clot formation and strokes. So we can have a neurologic injury via hemorrhagic or ischemic injury induced by us. We can also introduce air bubbles into the system, and via ECMO that can translate into going into their brain. We introduce obvious sites of infection, multi-organ dysfunction with renal perfusion, and ischemia as far as our distal perfusion, let's say you're in VA ECMO. So these are all complications of ECMO, and these are things that we're exposing our patients to. So we have to be very diligent in assessing our risk versus reward with these patients. Here's an example of some ECMO transport. So here's some intra-hospital transport right here and here. And here would be some like life flight activities, and you can see how intense it is. Taking an ECMO patient to CT, honestly, it terrifies me, it drives me insane. And they're always gonna have pump issues when they go in there. It's actually a very scary process, but it's doable. These machines are very portable, as you can see here. Here's a cardio help right here. And here's a baby in a box. But ECMO transport is a skill. It's something that if you're an ECMO specialist that you have to be relatively comfortable with, and you have to be very proficient, because anything can go wrong, and you're not losing an airway, you're losing a cannula in a major vessel, and that's not a really good look to have. So you guys have been introduced to a ton of information. I did most of this more for your knowledge. There's so much more I can go into with ECMO, even like emergencies with the circuit and things like that, but you guys have an exam coming up, so I just wanted to give you some good information. Refer to your study guide. I'll be going over that next week because not all of this information is on there, so don't get overwhelmed, but I know this is something important for this class, and I like talking about it as well. So reach out to me with any questions. I'd love to go over some more of this information, so if you have questions about that, I'd be more than happy to spend time with you. I hope you enjoyed this, and I hope it cleared some things up as far as some of our advanced ventilator strategies and ECMO. All right, I will see you next week for the exam review.